I'm Sarah, I'm one of the care coordinators in the community team in Portsmouth. So I have been doing a project as part of my Masters in Advanced Clinical Practice. So my project consisted of supporting care coordinators in using the physical health check tool, which was devised by Fellon et al. But has been used by Rethink. And it's a tool used in identifying physical healthcare needs. And we did that over a 3-month period. At the end, I did an audit. We had quite a limited uptake of people using the tool for a variety of reasons. But the audit that I did, we compared the physical health care plans of the 18 service users who'd completed one with a random 18 service users and compared the results. And we identified 6 key components of a good physical health care plan, which were things like identifying known physical health conditions, identifying the treatment for them, key professionals involved in their physical health, their annual health check by the GP, any support that people required getting to appointments, and also service users' insight and ability to self-manage. So we kind of looked at those 6 key things between the 2 sets. As you can see, the red is the people who'd completed the physical health check tool. And it kind of quite clearly shows that the use of the physical health check tool dramatically increases the chance of there being a physical health care plan to start with. Those 6 things kind of correlate to the 6 questions I just mentioned. Obviously still got quite a long way to go, and a kind of statistical analysis which showed that there is a positive kind of correlation between using the physical health check tool and having a good quality care plan. Some qualitative data. Practitioners liked the tool, they liked using it, and felt that a lot of service users could use it independently, didn't need support in completing it. A lot of practitioners didn't feel confident in assessing physical health care, and that's something that's kind of been discussed already here today, and training is a big issue.
We've got social workers and OTs in our team who don't feel that they can do a blood pressure or check something or go out and do that or make that judgment.
Feedback from service users, although it was limited, they kind of quite liked the tool, found it useful.
Some of them quite like to do it on their own, don't they? Yeah.
Obviously the uptake of the tool is limited, but the reasons for that, we feel like it's a new intervention. It always takes a little while for it to kind of be taken up properly. Lack of confidence in assessing physical health, perceived lack of time, and the difficulties with the Rio was that the tool doesn't map to the physical health assessment at all on Rio. But the bottom line was that the use of the tool did improve the likelihood of having a physical health care plan and improve the quality of those care plans. So some recommendations quickly we made were that the routine use of the tool at CPA review, care coordinators to request medical information from their GP, obviously some difficulties involved within that, but we thought maybe some kind of pro forma facts to be arranged. Training course on physical health and care coordinators. The nurses also felt that, especially when they've worked in the community for quite a long time, they felt that their physical health assessment skills had been neglected a little bit. The standardisation of physical health care plans to encompass those 6 key questions, areas, supporting people in attending annual health check with their GP, and also considering appointing a physical health practitioner in the CMHT, so we have Jacqui specifically within the CMHT, we thought that would be really useful. And of course, I guess the clients, whether that's very much in the community, the clients that we're working with in the community are the people who are going to be in the inpatient unit, so kind of having that information already on Rio would be really useful for the inpatient staff if they do get admitted.
Yeah, so I mean it's sort of like a template type care plans, but to help people, to help to inform. Some of the other challenges really, I mean one of the big ones for me is primary care. It's working really closely with primary care so that we're getting it right, from start to finish, because things go wrong on admission, things go wrong on discharge, Something we're doing at the moment is, anybody heard of Muse? Muse, the deteriorating patient. Well, we got the Royal College of Physicians have agreed to us adapting it in Solent to a psychiatric response, so that we are using the physical, because it was originally set up by a group of people in Portsmouth. There was an anaesthetist, Gary Smith, and they set up this literally your scoring system, and one, and you need to keep a close eye on the patient in terms of the physical parameters, 6, and it needs to be a blue light and they need to go. But obviously we couldn't follow the general acute hospital settings, we followed the pre-hospital ones, so we're doing that at the moment. We're in the middle of a study to look at that, so that we're not getting near misses and we're not getting people getting really ill on psychiatric wards, and we don't know about it, we think that they've got a stomach bug and actually it's appendicitis or something like that. And our long-term quality account, our quality account is linked in with older person's mental health, and it is all about this care planning library and sharing that sort of thing. And I think some of the challenges for the future is doing, as Amanda was saying, is like the sleep work. That's another one. Our substance misuse team used almost that and reduced the amount of PRN and sedatives at night. I literally halved it on the substance misuse residential unit. Amazing, absolutely amazing. Yeah, I think that's about it. I'll probably bundle on too long, so thank you very much.